Welcome. I'm Jerry Sherman, and the first lecture today that we're going to be covering is detecting lesions with wide field color and autofluorescent images, and then diagnosing the detected lesions with OCT. Rather long title. I hope it makes sense to you. As for disclosures, probably any of the technologies that we're going to be mentioning, I've probably lectured for that company. Okay, here's the first one. Here's an ultra-wide field image, and the first thing we actually could look at is the optic nerve, which is over here, and some drusen of the macula. But in this right eye temporally, we're seeing a very, very large lesion, as you can see, and within that very large lesion there are smaller lesions. So this is sort of part of an ultra-wide field image in color, and the question is, now we want to use perhaps OCT to make a differential diagnosis of actually what's going on here. So let's outline this. The blue outline is actually telling us about the larger lesions, which is actually a retinal schisis. And the smaller ones, the 5 small ones, are actually something that we'd like to get a little bit more information about. Those are probably something that are related to the retinal schisis. Here we're looking at it in red. We have the color, which was back here, and then we can separate it into red laser separation and green laser separation. That's probably not giving us a lot of information. But here we actually did an OCT of this lesion. Here's a vertical section, as you can see. I think that's showing up. I think you see my pointer. And below this blue horizontal dotted line, we're down here. And we have, in a sense, a split within the retina. We can see the outer retina, we can see the inner retina, and between that we see a split. That's called a retinal schisis. Then above here, this would be above this blue horizontal dotted line, which would be here. So this section would be within this large circle, if you will. There is an inner retina, which is present, but the outer retina looks like it's missing. So therefore, what we have is a retinal schisis below, a split in the retina, and above we have an inner retina without an outer retina, and that would be an outer retinal hole as labeled here. It turns out that this patient has a very large schisis with 5 outer retinal holes. These patients, interestingly enough, can be followed. They don't need treatment at this point in time. If a patient has inner and outer retinal holes, they do need treatment, but here they don't. So this patient can just be followed. So again, the concept is we first did a wide field image on a patient who had no symptoms. We saw something that looked like this, and then we got a little bit more information about it and did an OCT through the lesions, which allowed us to make the differential diagnosis. So in this case, we're actually seeing a retinal schisis and these 5 outer retinal holes. Here's another case. Again, an asymptomatic patient. We're seeing 2 lesions in his right eye temporally. We're showing those 2 lesions with the blue and the black arrows, blowing it up a little bit. And now we can get some cross sections through it. And you can see that up here we took a cross section through the top lesion, and below we took a cross section through the bottom lesion. So this one corresponds to an area just about over here. Okay. Notice that the top lesion, this top cross section OCT, which is at about this level, is showing us a retina, full thickness retina, separated from the retinal pigment epithelium. That would be the green arrow. And that is really a retinal detachment. Retinal detachment, by definition, when the 9 layers of the neurosensory retina are separated from the retinal pigment epithelium. Below down here, we have something different. The retina itself looks thinner below, because it is thinner. And as you can see, it looks like it's being torn apart. The one below is actually a retinal schisis. So this is a retinal schisis below, with some little white spots on the surface, which relate to some degeneration of the inner part of the retina. And above we actually have, which is a retinal detachment. So this patient probably had a retinal schisis leading to retinal detachment. And of interest, this patient also doesn't have to be treated. These patients can be watched. A small number of these will progress into the macula, only about 1 in 350 or so. So this type of combination is a retinal schisis leading to a retinal detachment. This retinal detachment, at this point, doesn't really have to be treated. In any instance, these are not common lesions, so it'd probably be a good idea to get a retinal consult on such a case. Here, a different case, we're showing a cross-section and just giving you a sense of here's the fovea of this patient. In 3D, you can see this separation of the neurosensory retina. Here we're seeing a separation of the neurosensory retina from the retinal pigment epithelium. So this is actually a retinal detachment, which we can diagnose just with an OCT. It's fairly typical. This is a retinal detachment where the macula is still attached. So it's a macula on retinal detachment. And these become emergencies because we don't want this to progress to affect the macula, where the macula would be off. In that instance, the prognosis would be worse. This one is a little bit different. Here we're getting a cross-section. We're actually seeing not sort of a single separation. And this is at a high resolution, this one. But here's 9 layers of neurosensory retina separated from the retinal pigment epithelium over here. We're seeing some small cystic spaces. Happens to be a very high resolution scan. In this one, we're seeing multiple sections, if you will, multiple separations. And this is actually a retinal schisis. So in a retinal detachment, back here, we're getting the entire neurosensory retina separated from the RPE. In a retinal schisis, multiple splits will be seen. The PIL, by the way, the photoreceptor integrity line, is still intact over here. That's telling us that this patient will still have relatively good vision. And this is what it looks like in 3D. And that's what it looks like clinically, which really is not much for at all. It looks like this patient has a tilted disc with a bleak entrance, with a scleral crescent, but the area that's actually split over here is really pretty much invisible to ophthalmoscopy of interest. Looking at this case, we have above, case 4, the retinal schisis, where we're getting multiple splits within the retina. And below, we're actually getting all of the retina, except for the retinal pigment epithelium, separated. So this is actually a retinal detachment. This one actually is folded. It folds within the retinal detachment, not that unusual. But the retina itself is completely contained together, if you will, but separated from the retinal pigment epithelium. That's the definition of an RD. Above the schisis, we actually can see multiple splits. A lot of these cases are covered in Retina Revealed, which is a free website. We're now up to about 2,900 images, and it's free, and it can be you can easily get to it at www.retinarevealed.com. Go under Archives, and you'll see something like 60 cases, groups of cases, and hundreds of images. Actually, now up to thousands of images. This is an eye scan. We're talking in terms of this lecture of actually looking at everything at once with an Optos instrument, which gives us about 200 degrees by 200 degrees. The OptiView people have come up with an eye scan, which is a sort of a system that runs itself. Patient puts their head in, and the instrument tells the patient, open your eyes, close your eyes, look at the blue light, look at the red light, and it does an OCT all by itself. So it's sort of an automated OCT, which is pretty interesting. And we use one of these in one of our offices in Manhattan. And it works out quite well. We do it on practically every patient. Here we actually have an image, which was taken with an iPhone, of one of our techs running, and you can see it's a panoramic image. So here's the same patient being OCT'd, if you will, on the eye scan, and while this technician is also setting up a patient over here on a matrix, and over here further to the left is a VEP instrument, and setting up a patient on a VEP. So we like technicians who are multitasking, who can actually go from one instrument to another and run 2 or 3 patients simultaneously, and that works out okay. Going back to something we mentioned earlier, the cross-section of the retina. This is over here an OCT on the right and histopathology on the left. This is the foveal pit that we would anticipate finding. When we started to do spectral domain OCT, we recognized that there was a line above the retinal pigment epithelium. Here we're showing you the retinal pigment epithelium with this green box going across. And above that is a thin, bright band, if you will, that we call the PIL. This was named PIL because I thought it was telling us about the photoreceptors, both rods and cones. And it does, and it is a line, but it's really telling us about the integrity of the photoreceptors. So it was termed at that point PIL. Has a couple of other names in the world's literature, probably about 6, if you will. Some people use the term junction, which is now something that is been shown that it's really not the junction of the inner and outer segments of the photoreceptors. The term PIL still works because it doesn't talk about the microanatomy. It just says it's a line that tells us about the photoreceptors, cones essentially, rods peripherally, and it tells us about the eye, the integrity. And of course, the word pill is very easy to remember. Slightly higher resolution of the same scan. We can see the PIL or junction shown right over here. And under the fovea, the PIL or junction will be ever so slightly elevated. That's normal. And that's because of the fact that the outer segments of the photoreceptors are actually a little bit longer and narrower. So this appearance is actually normal. In this cross-section, all the different layers are named, as you can see. The retinal pigment epithelium is down here, almost like a double or a triple layer, if you will. There's a term called Verhoef's membrane, which has pretty much been rejected. It's not being used anymore. There's an interesting thin band up here that we call the ELM, either the outer or limiting membrane or the ELM, external limiting membrane. ELM, I think, is a little bit easier to remember. And that, of interest, never seemed to have any significance until recently, which we're going to show you a little bit later, has great significance when we talk about a condition called Stargardt's disease. Matter of fact, this line becomes hyper-reflective at even age 4 in patients with Stargardt's, and that's a published series. In Eye and Brain, we published an article going back about a couple of years, and we actually were interested, can you use an OCT for just looking at sensitivity and specificity? Meaning, if you ran everybody, how good would an OCT do? Will it be able to pick up the sensitivity, meaning patients who have disease as having disease, and specificity relates to the patient doesn't have a disease, if they're normal, would the instrument do a good job in identifying normals as normals? And this was done with a graduate student, Catherine Awad, and it turned out that the results were so good we decided to publish them. A second one was just published last week, where we actually went a little bit further and used novice observers. In this instance, I looked at several hundred sets of scans and made a determination in about 10 or 15 seconds as to whether a patient was normal or abnormal. If abnormal, was it optic nerve disease, was it retinal disease, or actually was it both? Remarkably, the sensitivity and specificity were very, very high. Sensitivity, we can say the percentage of sick people who correctly identified as having the condition as being sick. And the specificity is the percentage of healthy people who correctly identified as not having a condition. And in normal subjects, specificity 99%, patients with retinal and optic nerve disease, sensitivity 96%. So remarkably high numbers, which really tells us OCT perhaps does have a place in screening everybody. If you're using one of these systems like the eye scan, if you will, you can do it in about 2 minutes, and you can actually run everybody in your patient in your practice with great success. You can also take ultra-wide field images of everybody with Optos, which also makes sense. And I know some clinicians that actually do both in everybody, and they have very successful practices. Actually some young doctors, and their practices are growing by leaps and bounds because they're providing a very high level of care. Going back to the cross-section of the retina with OCT, as shown over here, and again there's the PIL, photoreceptor integrity line, we know that cones have a high concentration under the fovea, right about over here, and then they drop off rapidly. And just a few degrees away, 10-15 degrees away, we have the peak of the rods. So really the PIL tells us about the cone centrally, but outside of this area it tells us about the rods. So photoreceptor integrity line, PIL, tells us about all the photoreceptors, the 6 million cones, and also the 120 million rods. And that line should go all the way across in a, this is a 6 millimeter scan, completely across in that 6 millimeter scan. So if the PIL is not present, there's a problem. Here's a system which goes a little bit further out. Rather than a 6 by 6 millimeter scan, it actually is capable of 12 by 9 millimeter scans. The system is called the Avante, and the Avante has certain advantages. One, higher resolution scans larger areas, but it also has the capability of picking up abnormalities at the level of the choriocapillaris, where there are new blood vessels growing. And that's something that we'll perhaps touch on in this lecture, but in other lectures as well. Here we're looking at a 12 millimeter scan, and remarkably we're getting the optic nerve and the macula in the same scan. We're seeing the vitreous in greater detail than we've ever seen. We can actually look down and see these large oval these large oval zones, which are actually the vessels in Howard and Sattler's layer of the retina, and below that we can actually see where the sclera begins. So OCT is becoming amazing in that it's giving us information well beyond what we get with an ophthalmoscope. Here's a 13 millimeter scan, at least it's labeled 13. The system I haven't been able to go beyond 12 millimeters. But of interest, you can see a tremendous amount of the retina. Here's the vitreous in a normal individual. This actually a patient is normal. So the vitreous actually does show up. We're getting the PIL shown over here in great detail. Here's the foveal pit. Here's the optic nerve. And the choroidal vessels, again, these circles telling us about the Howard and Sattler's layer. The choriocapillaris you don't see because they're too fine. But OCT is really remarkable in that it gives us so much more information than just ophthalmoscopy all by itself. Of interest, this last scan we showed, where we were able to, if you're trying to visualize the macule, you're also getting the disc because of the fact that this one is actually 12 or 13 millimeters across. In the series that we looked at, we actually looked at myopes over the age of 10 diopters, and a significant number of these patients actually had splits. This is a retinal schisis. Again, multiple splits within the retina. This is a schisis. This over here is a right eye, so the schisis is nasal. It's a horizontal cross-section. This is also a right eye, showing us in grayscale as opposed to color. And down here, we're seeing the same. Notice that we're getting these, this is now the left eye, and we're getting the nasal cross-sections over here are showing us splits. So splits within the retina in high myopes, actually not rare. I think we've seen 25 of these over the last several years. We should really put them all together and document them. We've seen one patient where it goes all the way around, sort of a 200 or 360 degree schisis. So that would be a true schisis all the way through. We can talk about pericentral schisis or schisis that goes all the way around. So this one is actually just nasal. So it's sort of not completely a complete circle. It's not circumferential completely. Let's go back to Optos for a moment. The standard Optos systems, the P200DX, there are a lot of these out there. They're very, very good. The Daytona is a newer system which has some advantages over the older system. The major advantage of the Daytona is it's smaller, a little sexier. I don't know if that really helps, but it's really a sleek system. It almost looks like it was designed by Apple engineers. But it does give us autofluorescence. And autofluorescence is a very unusual, or I shouldn't say unusual, a very useful new technology. It's unusual for those who haven't used it in the past, because you start to see things that we've never seen before. Here, by the way, is a 200 degree image with an Optos with a Daytona. Normal autofluorescence is over here. This is telling us about lipofuscin, primarily, which is within the retinal pigment epithelium. This dark zone, here's the optic nerve, and here's the macule. And you can see this sort of strange looking lesion. This patient has a retinal degeneration, a type of retinitis pigmentosa. Of interest, if we turn that by 90 degrees, we can say, gee, it looks like a question mark. And we can say, what novel information does autofluorescence give us? Well, it tells us about the retinal pigment epithelium. It tells us if the retinal pigment epithelium is healthy, such as over here. It tells us if it's a hypoautofluorescent, which is, too dark. It's actually, and that means the retinal pigment epithelium is dead. And sometimes we actually do get a zone around it. So this is like a hyper-autofluorescent zone, suggesting, where we get the bright spots, that the retinal pigment epithelium isn't dead, it's actually metabolically active or sick. And if you do nothing about it, the chances are it will die. So, the novel information that we get in hyper-autofluorescence, which means there's too much, zone over here, hyper. This is accumulation of lipofuscin, and it results in increased autofluorescence and suggests, as we mentioned, RPE dysfunction, stress, or just being under too much, there's too much activity being present. In hypo, HYPO autofluorescence, we can see that there's a decrease in autofluorescence. That's this dark zone over here. And this suggests that they actually have dead retinal pigment epithelial cells. So we can have normal, hyper, or hyper, and they're all a little bit different, give us a different bit of information. Here we're taking that question mark in a real image. and comparing it to an image over here. And again, if you can see the analogy, the grass here is burned. It's dead. It's dying. It's gone. Okay, that would be the hypo-autofluorescent zone here. But around that, it's hyper, if you will. The grass is burning, but it's still not dead. We talk about here metabolically active or sick, but we can see dead versus dying, if you will. The analogy in this image is from Jeff Gerson. We put it together with this image from a patient that I know. Of interest, indirect ophthalmoscopy is still, of course, a very important technology, but no form of indirect ophthalmoscopy or direct ophthalmoscopy tells us about autofluorescence. So autofluorescence with some of these systems, and most cameras are able to do it. You have to decide when you buy a camera nowadays if you're going to get autofluorescence as a part of it. Certainly, they don't come for free. They're extra on the vast majority of cameras. The one that goes out to 200 degrees, the Daytona, I think now you can't get a Daytona without the autofluorescence. Abnormalities of autofluorescence could be lots of different things. This is from Retina Revealed. We talk about the vitamin mnemonic. Vitamins spelled with an extra E, as they do in Canada, and something can be due to an etiology. It could be vascular, it could be a vitamin deficiency, infectious, inflammatory, perhaps due to trauma or toxic. So if you can just remember this, and again it's available in Retina Revealed, the word vitamins and all the different etiologic categories. So you have these myriad etiologies which you can think about when you see a patient with a lesion. Just think in terms of what could this possibly be? And if you go through this mentally, there's a chance that you'll come up with something. You might say, gee, I forgot about inherited. Maybe a patient has an inherited disease. Half the patients I see are idiopathic, and when my patients ask me what that means, they say, does that mean my doctor is an idiot? And I usually say, yes, but I can't figure out what you have. Over here, we're looking at normal colors with, these are Daytona images. So this is a color shown here of the right eye, color of the left eye, and the corresponding autofluorescent images. The colors are made up of green and red lasers, green laser separation, red laser separation, but if you put them together in the composite, they look like this, and we can compare them to what we get with autofluorescence. Again, this is in a normal individual, so it's rather not too exciting. How about examples of hyper and hypoautofluorescence? Here we have some examples, and what's going on here in this left one, this is obviously hyperautofluorescence. It's brighter than it should be, which means it's metabolically active or sick. Over here on the right, we have some hypoautofluorescent zones, which typically would mean that these cells, that the retinal pigment epithelium is actually missing. There's some exceptions, which we may get to a little bit later. Let's talk about choroidal nevus. Choroidal nevus is a very common finding, found in about 10% of patients with ultra-wide field imaging. And as we'll see, in addition to hyper and hypoautofluorescence, which we've already discussed, normal fluorescence is sometimes called isoautofluorescence. Here's a typical image of a patient who, it's a left eye, here's the macula, here's the optic nerve head, the vessels, and going out about 5 diameters or so, there's a dark area that shows up. These vessels here, these pigment, are showing us, some choroidal vessels and some pigment from the choroid, but this is certainly separate than this pigment here, and it's round. It suggests, choroidal nevus, which again is common, close to 10% of the population. We can look at it in green laser separation and red laser separation. A typical nevus will occur at the level of the choroid, and at the level of the choroid, it's going to be missing on one of these two zones, on one of these two scans. Turns out that if we use green laser separation shows us the retinal vessels very, very well, but it doesn't really penetrate down into the choroid to any great degree. So it usually doesn't go much below the retinal pigment epithelium. In contrast, if we're using the red laser separation, and again, when we get a composite image, we're pushing a button, we're getting green and red together, but later you can go ahead and separate them out if you'd like to. And here, in this red laser separation image, we can see a lot of choroidal vessels, because with red laser separation, the red will penetrate under the retinal pigment epithelium and will give us detail about lesions or findings there. So all these choroidal vessels are showing up on the red laser separation. On the green laser separation, again, looking at things pretty much anterior or or in front of the retinal pigment epithelium, we're seeing the retinal vessels and not the choroidal vessels. Notice the lesion. The lesion shows up quite well where the lesion shows up quite well over here on the red laser separation. You know it's red because we have a red rectangle around it, and it shows on up on the composite, which is a comparison of these two. We're putting these two together. How about an autofluorescence? Well, autofluorescence, we said, is telling us about the retinal pigment epithelium. Abnormalities in the retinal pigment epithelium. Hypo, hyper. So if the abnormality is below the retinal pigment epithelium, as we're seeing here, it's not showing up on this scan, on autofluorescence it's going to pretty much disappear. So the typical choroidal nevus is not going to show up on autofluorescence. It really means that the retinal pigment epithelium is intact, and what's under the retinal pigment epithelium is where the lesion is, such as over here. But this is very typical of just a choroidal nevus. The composite color, the red and green combined, compared to the autofluorescence, is showing us that the lesion is missing on autofluorescence, again because the lesion is under the retinal pigment epithelium. It's at the level of the choroid. So that probably makes sense. The general rule is what I do if I find a lesion with ultra-wide field autofluorescence or ultra-wide field color, I'll then take an OCT through the lesion. And that nevus is actually not completely flat. It was actually elevated by about 133 microns. We get concerned when lesions are elevated by 1 to 2 millimeters. This is just about a tenth of a millimeter in elevation. So it is elevated, but to a minimal degree. And all the structures look like it's intact. Where is the nevus? The nevus is really right about over here. And it's just pushing everything ever so slightly forward, which you may pick up with a binocular indirect, but probably not. But you can pick up with an OCT. OCT gives us the ability of looking at 5-10 micron resolution. How about the next one? An amelanonic choroidal mass. Here's an interesting lesion. It shows up in color in the left eye in an asymptomatic patient who's actually from Russia, is about 45 years of age. And you can see the lesion here. On autofluorescence, it's hyper-autofluorescent, as you can see. It's an example of hyper-autofluorescence. And we get concerned about these lesions. It's hyper, which means it could be a lot of things. It's active, if you will. It could be a melanoma, even though it looks white. It could be an amelanonic malignant melanoma. It could be a nevus. It could be a granuloma. Granuloma due to something like sarcoid or syphilis or tuberculosis. So it's certainly possible that it's an inflammatory lesion or a serious disease, like a melanonic malignant melanoma, or it could be a metastasis. It could be a lesion somewhere else in the body, in a woman certainly from the breast, in a male certainly, let's say from the lungs, from somebody who smokes. If you follow these patients and you go through the differential diagnosis, often it turns out to be a single isolated lesion. Nothing is found systemically on a systemic workup. And the term that's sometimes used is solitary idiopathic choroiditis, or SIC, a term which I think was introduced into the world's literature by Carol Shields. Anyway, these cases we're concerned about because they could be serious. Here's what it looks like blown up, and blown up a little bit more. And over here on autofluorescence, it's obviously hyper-autofluorescent. And yes, we're going to want to do an OCT through it. Again, the general rule is ultra-wide field color and autofluorescence on everybody, if you can. And then anytime a lesion shows up, try to get an OCT through the lesion. And here's the OCT through that lesion. So we can see the lesion is under the retina, under the retinal pigment epithelium. It's affecting the retinal pigment epithelium. And that lesion is elevated by about 2/3 of a millimeter, okay, about 650 microns or so. So we have concern about this. This patient deserves careful follow-up. We probably should get a fluorescent angiogram, a retinal consult, and probably a systemic workup for the granulomatous type of diseases that we talked about, toxoplasmosis, and we talked about toxo, certainly a possibility. Go back one more time. That slide. Sarcoid in a black individual would be certainly possible. Syphilis can look like anything, can look like this as well. So there's a lot to consider in this in this case. So this is a case that I would not dismiss. I would have this patient worked up for various of the etiologies that we just discussed. CHRPE lesions, common. How common? About 9 to 11% of patients have CHRPE lesions, congenital hypertrophy of the retinal pigment epithelium, which means it's congenital, it's been present at birth, and it's actually hypertrophy of the RPE. So the RPE is actually thicker than it's supposed to be. Here's what it might look like in color, and here's what it will look like in ultra-wide field autofluorescence. Carol Shields, who I know and actually asked her this question, how many of these CHRPE lesions that she's seen, and the answer was about 250. And she said on autofluorescence, everyone she's ever seen has been dark. So they are actually dark lesions. So they're examples of hypoautofluorescence. Now here's an exception. That doesn't mean that the retinal pigment epithelium is dead, because we're really talking about hypertrophy of the retinal pigment epithelium. We'll discuss that. We'll try to describe how that works in just a moment. Here's a patient of mine, it's actually a student, a resident, who showed a lesion. Her last day of her residency program, she asked me to take a look at it. She wouldn't let me dilate her. She said, why don't you take a look and, do an optos, and you want to get a cross-section with OCT, that's okay. Tell me what I have. In any case, it did show up on autofluorescence. And we know that CHRPE lesions do show up on autofluorescence. So it could be a CHRPE lesion. We would like to get a cross-section through it, and we did. And here it is. So notice, first, the retina is a little bit thinner in that zone. The second thing to perhaps notice is the fact that the retinal pigment epithelium, in contrast to what you might have expected it to be missing, is actually thicker, because this is really congenital hypertrophy of the retinal pigment epithelium. Okay. The other thing to notice is the PIO, the photoreceptor integrity line, is present here, but missing where the lesion is, which means if you actually can do visual fields on this lesion, there will be a visual field defect because the photoreceptors are missing. So this is very typical of a CHRPE lesion. Again, sometimes we get multiple CHRPE lesions as shown here. Sometimes they're isolated. We do get concerned about the relationship between CHRPE lesions and colorectal cancer, as you probably know about. And in a patient at age 10 with one lesion, I probably wouldn't do anything. A 50-year-old who's never had a colonoscopy probably would recommend a colonoscopy because of the possible relationship between colorectal cancer and CHRPE lesions. Next case. What's going on here? Well, normal fluorescence is shown here. I can tell you this patient is 8 years of age, actually referred to me by my brother, 8-year-old male, who's had vision that's lowered. It started about 20/30, went to 20/50, 2100, 2200, seen by, according to mom, 15 different doctors, and they all looked at him and said that he's okay. This is what it looks like clinically. You don't really see very much, maybe a couple of tiny little white spots, but the clinicians who saw him previously, months earlier, years earlier, always thought he was okay. He may have been just hysterical and malingering. However, one simple autofluorescent image shows over here that clearly the macula is too dark. It's oval. It's darker than it's supposed to be. That's hypoautofluorescence, which means that the retinal pigment epithelium is missing. The other important factor is when you lose the RPE, you also lose the photoreceptors. So he would be expected to have central acuity loss. This is right in the macula. In addition to the area that's hypoautofluorescent, you can see there's large zones of hyperautofluorescence. So these are zones where the retinal pigment epithelium is sick or metabolically active. The dots, spots if you will, or flecks, are suggesting a diagnosis, suggesting that this youngster has Stargardt's disease. Has a maculopathy and has flecks, and that's very typical of Stargardt's disease. Again, you may not see it in color, but you can easily see it in autofluorescence. Now, most of these hereditary retinal degenerations, probably about 98 to 99%, are very symmetric. So here we're showing the right eye versus the left, and we're seeing almost perfect symmetry between the two, suggesting that this is indeed a retinal degeneration. The color images above really are not showing much. The autofluorescent images below are rather dramatic. Now, again, the concept is we have images, ultra-wide field images on the bottom here. Let's do an OCT through it and see what we find. A normal OCT is shown on the right, as you can see here, and all the different layers are labeled. And over here on the left is our youngster, 8 years of age. And notice, the first thing you're going to notice is a very thin fovea. In addition to that, you'll notice that the outer retinal lines or layers, the PIL, for example, and the external membrane, all those bands are missing. So he has outer retinal degeneration, which is typical of Stargardt's disease. Of interest, I had the opportunity of looking at his sister, who was 5 years of age. She had normal vision, 20/25 acuity when we pushed her, and no symptoms. Reflections off her internal membrane, which are very typical in youngsters. But when we did the autofluorescence, we got rid of the reflections because the autofluorescence tells us about the outer retina, the photoreceptors, and specifically the retinal pigment epithelium, and secondarily the photoreceptors. And all that stuff going on in the inner retina, reflections off the internal membrane, ganglion cells, neurofibrillary, all that does not show up on autofluorescence. But we can see, with a little imagination, that she actually has a bullseye in both eyes. Bullseye maculopathies are common findings in Stargardt's. So this 5-year-old with normal acuity may actually have Stargardt's. Of particular interest, when we did the OCT through these lesions, she showed something that at the time I had never seen before. And that was a very, very thickened external membrane that we're showing here in yellow. So that line here in a normal should be extremely thin. It should be about 5 to 10 times as thick as the PIL, the photoreceptor integrity line, but hers is actually thicker. And it's the first time I've actually seen that. Here we're seeing it in grayscale, here we're seeing it in color below, and it's very obvious that the external membrane is thicker than it's supposed to be. That's the left eye. She has the same finding in the right eye. And then we had the opportunity of looking at her younger sister, the 4-year-old. And the 4-year-old also had an abnormality on the OCT. The same kind of abnormality, we could label it the same way, where the external membrane is just too thick, thicker than it's supposed to be. And this 4-year-old also had normal visual acuity, 20/25 acuity in both eyes. And both of them have a form of Stargardt's, and they both have worsened over the last 2 years, and are starting to look more and more like their brother. So 3 kids in the same family with Stargardt's disease, which is autosomal recessive. The statistics are probably 1 in 64 of that happening, so it's fairly unusual. Here's a normal OCT, and here's the 5-year-old with a very, very thickened external membrane. And now we know, based upon some studies that were done afterwards or more recently at Columbia University, that Stargardt's patients do have this thickened external membrane when you compare it to a normal. And we now know that this is a novel finding, which is a biomarker for very early degeneration in Stargardt's disease. Turns out in Stargardt's disease there are 800 different mutations or so, but there's treatment on the horizon, some treatments out there which look like they're actually going to work. Various forms of vitamin A. You modify a vitamin A molecule, and that actually may prevent Stargardt, so prevent it from progressing. So it's very, very exciting to try to make an early diagnosis of these patients. Again, normal for comparison, all those layers as we're supposed to see it. If you have an OCT and you start to use it, I would suggest printing out some normals and have them close to your instrument. So when you're looking at a patient with an abnormality, you're able to go back and forth and see the difference between normal and abnormal, and that actually may work. You can look at it in color, you can look at it in grayscale. Usually the grayscale gives us more information. Sometimes the color is more useful. Okay, what's going on here? We have a foveal pit, we have a PIL, as you can see, but of interest the PIL seems to end. And this is where the cones are, and then where it seems like the PIL is missing, that's where the rods are supposed to be in high concentration. So if you think about that, here's the patient's fundus, which you don't really see very much of, meaning there's not really much going on. But we had some subtle findings, and we were interested in it, so we did do an OCT, a normal OCT below. That PIL line should go all the way across. This is a 6mm scan, and here you can see in the patient, it doesn't go all the way across. It only goes across about 1.5 millimeters. This patient is missing something. The PIL is missing outside of the macula. This patient has a rod abnormality, and this is really retinitis pigmentosa. We can blow it up a little bit and show you the difference. And over here, the PIL is present in a normal peripherally, but in this patient, we can see the retinal pigment epithelium, but that line itself is the PIL, which is absent. We've seen at least 100 patients with retinal degenerations with retinitis pigmentosa. And this is a very typical finding, where if they have good acuity, 20/20 acuity, the PIL is going to be present centrally. They have dark adaptation issues and peripheral field issues because of the rod abnormality further out. So just the OCT, even without the fundus abnormalities, can help you make a diagnosis. Here's another patient with a very similar kind of a problem. we can see that the PIL seems to end. And over here, vertical sections, we can also see the PIL is present, but then it seems to end right about over here. Fundus doesn't look so dramatically abnormal, but this is also a form of retinitis pigmentosa. Pericentral CHRPE is the name of this disorder. And we can take some slices here. This is the fovea. For outside the fovea, we're missing the PIL. And we're getting a little bit of the retinal pigment epithelium that's migrating. And over here in the left eye, again, a cross-section that's not through the fovea, we can see we're missing pretty much the PIL. So it's very typical to be able to look at a fundus, even though there's only subtle fundus abnormalities, make a diagnosis when we use the OCT. And here's again sort of a blow-up of that. And we can see that there is some PIL present centrally, usually generally good acuity, and then it's missing peripherally to that. And the same story here. A slice right through the fovea, we can see the PIL present, it ends. If we take a slice above the fovea and a slice here below the fovea, we can see that the retinal pigment epithelium is intact, but that line above it, the photoreceptor integrity line, is missing. So, an ERG will confirm that this patient has a reduced function of the retina to confirm the diagnosis of retinitis pigmentosa. But OCT alone, or OCT in combination with autofluorescence, is usually very, very useful to make the diagnosis. Here we're actually looking at some pigment that's migrated from the retinal pigment epithelium to the large retinal vessels, which shows up on OCT. So you can use the OCT to do lots of different things. Again, that pigment is actually a normal pigment that is migrated from the RPE through the neurosensory retina, winds up wrapping itself around the large vessels in the nerve fiber layer, and that's what it looks like clinically, and here's what it looks like on OCT. All these images are actually in retina revealed. How about this one? Fluorescent angiography of something that's interesting, some dots, if you can see. This is a fluoro, so something is showing up, something is very, very bright. We can now look at the same bright sections with OCT, and of interest, here's that cross-section right about over here. There's another one over here. You might say, what could that be? Well, it shows up really well on the fluorescent angiography as a light bulb, if you will. And these light bulbs are actually aneurysms. These are not microaneurysms, but macroaneurysms of arteries. So that's what it looks like. And they leak. You can have exudative reaction, as we can see here. But these are actually cross-sections right through macroaneurysms that you can actually see with standard spectral domain OCT. The newer version, OCT, the standard versions have about 28,000 A-scans per second. The one I talked to you about before, the Avante, has 70,000 A-scans per second, and some systems are going up to 100,000 A-scans. So the better the resolution, as a general rule, the more we're going to see. The more A-scans, the better the resolution, the more we're going to see. But even with a standard one, a standard OCT nowadays, you can actually get slices through macroaneurysms, and that's a macroaneurysm. So you may see something on a fundus image, and then you can actually try to get slices through it and make the case. Here we're looking at the fundus image, here we're looking at the fluorescein, and it's like a light bulb, and here is a cross-section right through that same spot. And that is a macroaneurysm, a large retinal artery that is, in a sense, aneurysmal. There are aneurysmal dilatations. It's larger than it's supposed to be, and they show up as light bulbs on fluorescent angiography. Next case, cystic changes in the macula can be due to lots of different things. It could be diabetes, extrinsic retinal schisis. This is one you can look at and say, well, what does this patient have? Well, we might know from other findings. Here's what it's supposed to look like, the OCT. And there are lots of splits in the retina here. And if this is a youngster, and they have some difficulty seeing at night, and the acuity is down a little bit, this could be extrinsic retinal schisis. The ERG will show us an electronegative wave, which is typical, and that's how we can make that diagnosis. These are usually going to be bilateral, usually going to be males, sex-linked. Mom's going to be okay, but the mom's dad will typically be affected in these instances. And that's the radial pattern that we see. So every time we see a lesion on fundus photography, ultra-wide field standard, it's really not a bad idea to get an OCT through the lesion, and the chances are we'll get more information as to what's actually going on. Here's an interesting patient. Acuity is down a little bit in the right eye, 20/70, 20/25 in the left eye. Maybe some cupping. Patient actually does have glaucoma, but that's actually not why I'm showing you the images. But there's something going on in this ultra-wide field color image. And here's the left eye. Again, some vertical cupping. And there's some lesions here that are not at all obvious on the color. They will be very obvious when we go ahead and show you the fluorescent not the fluorescent angiograms also, but specifically the autofluorescent images. And here we are. This is AF autofluorescence. Again, we're seeing this descending tract, if you will. This was fluid at one point, still could be fluid. And you can see that the retinal pigment epithelium is sick. It's hyper autofluorescent, so you have sick tissue. We have some dead tissue over here, if you will, and this would correspond to a enlarged blind spot. Some lesions over here. And that's pretty dramatic. We can now look at the left eye. 3 lesions in the left eye that were not at all dramatic. I think what might be useful is if we do this, we can compare the color to the autofluorescence, and we'll circle 4 zones. Okay, this zone over here on color looked pretty normal. Obviously, hypo-autofluorescent dead retinal pigment epithelium. This zone looks minimally abnormal. This zone here actually looks normal, but that zone is showing hyper-autofluorescence, and the zone here looks normal, and that's showing it's showing hyper-autofluorescence here. So autofluorescence can give us additional information in a lot of conditions. In this instance, central serous. Central serous, we've seen so many patterns of abnormalities in central serous. A typical one would actually be this descending tract, as we just showed you. Even in the left eye, the color images are practically normal, not much going on, but we see 3 abnormalities over here, and we'll just circle them for you. And again, we're getting a lot more information on autofluorescence than we are on the color. We can do an OCT, of course, through it and show you and make the case that we have 9 layers of the neurosensory retina separated from the retinal pigment epithelium. So this is a retinal detachment, without a hole. So this is typical of central serous. There are also some spots over here, some retinal precipitates, if you will. So this is actually proving this patient has central serous. The left eye still has better acuity, so the left eye still has a PIL presently. The right one, you can see that we would expect reduced acuity as we take a slice right through the fovea. So central serous. Here's another case that you may recognize. Now let's look at it, right eye versus left eye. Let's look at the autofluorescent images. And there we are. This is actually an optometrist of interest, and he knows about this problem. He's aware of a blind spot, as we'll see in a second. Most of the lesion is infratemporal to the fovea. Hence, if he's going to be aware of a blind spot, it's probably going to be superior nasal. Here's his other eye, so it's mostly in one eye, mostly in his right eye. Very little going on in his left eye. Central serous can be unilateral condition, or often bilateral, but very often asymmetric. Again, the lesion, he has good acuity, 20/15 acuity. What's most significant is this lesion here, which is temporal and inferior. We can do OCTs through it and show some of the abnormalities, some of the separations are shown here, some retinal precipitates are shown here. Here's a space that we can see. And also similar abnormalities here. And here's a field defect. This is now of his right eye. We said the lesion was primarily infratemporal. The field defect should be infratemporal supranasal. And here it is. Okay, so we actually can plot a field loss that corresponds to this zone right about over here. How about retinal toxicity? Could be due to Plaquenil, Accutane. Here's a typical case. This is a little bit atypical in the age of the patient, and the patient is not on Plaquenil, but is on Accutane. It could be something else. It could be condystrophy, could be an early Stargardt's, but at this point in time, it looks like when he stopped taking his Accutane for his acne, his condition stopped progressing. His acuities were good, but he was complaining about difficulty reading. And when you look at him clinically, he really looks pretty normal. However, when you go ahead and do optos images, these are ultra-wide field blown up, in the red laser separation and the green laser separation, it looks pretty good, but what's going on over here? Clearly, there's a bullseye. That bullseye in autofluorescence is telling us that there's something abnormal. Bullseye lesions, typical for Stargardt's disease. We talked about that. Plaquenil toxicity, you have to be on Plaquenil, usually for 10-ish years or so. Accutane, a few cases in the world's literature. And there are a few other rare diseases where you can find that. But whenever you get a bullseye, you have to try to figure out what does this bullseye do to it. Is it toxicity? Is it a retinal degeneration? And when you start to look at the OCTs of these patients, here's a normal, and here he is below. You can see that there's tissue missing. He has 20/20 acuity, even though his fields are, he has trouble reading, because the PIL is still relatively intact right under the fovea. But on either side, he's missing tissue. And by missing tissue on either side means he can isolate single letters on the Snellen chart, but when he's trying to read fast, he's going to have difficulties because he has actually blind spots around his fovea. Here's the other eye for comparison. Again, the PIL should go entirely across, as you can see here. And here, the PIL is present under the fovea, but missing in both directions. So this would be typical for something like plaquenil toxicity for somebody with who's on plaquenil. Could be also cone dystrophy, could be Stargardt's disease, could be something unusual like Accutane toxicity, which may actually be the instance in this case. Here's the left eye, same kind of comparison. The finding that's most significant is here the autofluorescence, showing us that we have some active tissue. So the retinal pigment epithelium is sick right around the fovea. Right in the fovea is still a zone that's still pretty normal, and it's good acuities. Here's what it can look like bilaterally. And again, looking at these images, could be if patients on plaquenil, think plaquenil toxicity. If not, think things like cone dystrophy, their color vision is going to be down. Stargardt's disease is certainly possible. So if it's Stargardt's, look for flecks. This patient doesn't have any flecks. And cone rod dystrophies also conform to that category. And this rare Accutane toxicity. This image you saw before. Again, just reminding you, if we take images around the optic nerve head, amazingly, high myopes often have splits, retinal schisis. This is not unusual. I think we've seen about 25 of them. So as we start to look at high myopes for looking at splits in the macula, which are well known, you should also image the disc and look at the images of what's going on in the disc. Here we go, some tissue which looks like it might be on the surface of the retina. You might see this clinically. It may be very subtle to you. The OCT is going to be much more helpful to show you that there's extra tissue. This could be inflammatory. It could be just traction of the vitreous onto the retina. Those are all certainly possibilities. And over here is another group of patients. One patient, we can see, again, the schisis, which shows up pretty well. This patient has schisis most areas right around the optic nerve head. Here you can see the schisis that's actually this is a myope, another about a 12 diopter myopia. So the schisis actually goes right into the macula, or right below the macula. Here's the fovea. And splits in the retina are not that unusual, but hard to see clinically. This patient has another schisis. You can see a split here and a split here. Here's the optic nerve head. So these are not that unusual, and they show up really, really nicely with OCTs. This patient has an inflammatory disorder, systemic lupus erythematosus by history, and you can see some extra tissue sitting on the surface of the retina and tugging. So whenever we see something like this, we might want to get an OCT where we may get some more information about what's actually happening to the internal membrane and to the posterior hyaloid. Here's a patient with peripapillary retinal schisis. Here's a schisis right through all these zones. We have one around the disc that we showed you before, and here the schisis is actually in the macula. Here's an interesting one. Can you visualize what this is going to look like in color? Well, that's what it looks like on ophthalmoscopy. So here's a vertical slice and a vertical slice. And what this is subhyaloid hemorrhage. These are actually red blood cells. And these red blood cells, these little tiny dots, are, in a sense, settling into this zone over here. So you may think, what does a pre-retinal or subhyaloid hemorrhage look like on OCT? And here's a perfect example of it. How about vessels growing off the disc? These are new blood vessels. This could be in a diabetic or a lot of other disorders. It could be in a vein occlusion, or in some more esoteric disorders where vessels are actually growing off the retina. And some of this may or may not be visible ophthalmoscopically. You may see something, but you may have some difficulty picking up some of the detail. OCT extremely useful to show us new vessels growing from the retina into the vitreous. Dots and spots, lots of different conditions have dots and spots. And we have a couple of articles written on this one, published in Eye and Brain. We did this in Retina Revealed also. We have dozens of patients with dots and spots, and OCT is very, very useful to tell us which ones are where. So we're not going to have time to go through the differential here, but the important factor is shown over here. If you have these little tiny dots in the middle of the retina, this is actually the outer plexiform layer, this is very typical for diabetes or vein occlusion. So little tiny exudates or spots, these are going to be exudates in the area of the outer plexiform layer, chances are that's going to be a diabetic patient. Okay, shouldn't have dots like that. And these hard exudates in a diabetic. Turns out that most hard exudates are visible to ophthalmoscopy. They're below 25 microns in size. And if they are above 25 microns in size, you'll see them with an ophthalmoscope. If they're 5 or 10 microns in size, like most of these, they'll be pretty much invisible to ophthalmoscopy. And if you do a count, we'll see far more when we go ahead and actually count them with OCTs. And just another example of those. In addition to the ones where we see spots in the middle of the retina, outer plexiform layer, we can see spots under the retina, some of them big, some of them small. These are under the retinal pigment epithelium. These are typical drusen. And here are slices and showing the drusen. So drusen could be big, drusen could be small. We can have a drusen histopathologically. We can turn it around, if you will, and show you that it's really sitting right on Bruch's membrane, and it's sitting under the retinal pigment epithelium. That's how most of them are. We could also have some zones where it looks like a dot or a spot, but when we do the OCT, we see tissue is missing. So the PIL is missing here. That corresponds to this, that cross-section. So that's actually early geographic atrophy of the retinal pigment epithelium. Dry to wet mac degen. Here's a patient of mine that had dry mac degen in both eyes, went out into wet macular degeneration, showed up a few months later. This is a fibroglial scar. There's some fluid still present, and you can see a small hemorrhage up here. We can look at it with autofluorescence, some drusen still in the left eye. This is still a dry eye. And here in the right eye, this actually looks like a fold. It's actually like a rip in the retinal pigment epithelium. When that folds on itself, it's hyper autofluorescent, as we can see here. Toxoplasmosis, do we ever see a reactivation of toxo? Well, this patient came in knowing he had congenital toxo with reduced acuity. And he had multiple lesions all over the place. Of interest, one of his lesions was actually surrounded by a zone of hyperautofluorescence, suggesting that this was active. Again, this is just death of tissue, retinal pigment epithelium is missing, acuity's down because the macula is gone. But here it looks like you may be getting a reactivation. And reactivation of toxo, especially in patients with problems like AIDS, immune system problems, is certainly possible. Put on a 3-mirror lens, and it did look like he had some cells and flare in the vitreous right in front of us. So autofluorescence may be able to pick up abnormalities in toxo and making a differential between active and inactive toxo. Okay, so we covered a lot of information in maybe too short a period of time. The topic, of course, was detecting lesions with wide field color and autofluorescent images, and then diagnosing the specific lesions with OCT. I hope we have time for questions a little bit later, and we'll go into maybe some